All right, everybody, and welcome to another episode of This Week in Hearing. Today, I am joined by Dr. Victor Bray. Dr. Bray has a 40-plus year audiological career, including clinical services, audio R&D, including clinical trials of new amplification devices, senior administration in industry and academia, all of which have been supported with extensive presentations and publications. He is a tenured associate professor and former Dean of Salus University, Osborne College of Audiology. Dr. Bray, thank you so much for being here today.
David, it's a pleasure to be here with you. Thanks for the invitation.
Absolutely. Well, I wanted to have you on. I know that you and Dr. Amin Amlani have been in the midst over the last few years compiling a number of different analysis, statistical analysis of sort of the audiology workforce. And I know that you've been publishing some of your findings of late, and I thought this would make for a great conversation today. So just wanted to set the stage and just kind of establish what it is that we're going to be talking about. So in this most recent report that you all wrote, I found it to be very enlightening for a number of different ways. And I figured the best place for us to start might be all the way back in 1987, when some of the audiology founding fathers were sitting around at the formation of the profession. And if you want to maybe start by sharing George Osborne's 7-step outline that he proposed for audiology to basically have. I thought this might be a good place to, basically establish the context for a lot of the workforce data that you have been compiling and why this is relevant, which is what we'll get into as the conversation goes.
I think that you bring up a good starting point. We're talking about something that happened 35 years ago at a national meeting. This was 1987. And you have Dr. Osborne there, Dr. Beck, Dr. Jerger, a group of the leaders of the audiology community saying, what's our path forward? And out of that did come really a 7-point plan. And I don't think a lot of people know what the plan is. And I know that a lot of people are not working trying to make the plan help. And I've actually got a slide I can share with you that lists the points and that they do kind of come together in a few talking points. So there's an article that George Osborne wrote back in 2004. And there's actually online a 2003 interview of Dr. Osborne on Audiology Online, describing the current state of audiology. And for any of you who are interested, I advise you to go pull this up and read this. But the key thing is, in 2014, the Academy of Doctors of Audiology recognized Dr. Osborne's contributions to the AUD transition process and gave him the Goldstein Award. And Dr. Osborne, deceased at that time, I was able to accept it on his behalf. And we republished the article from 2004 in 2014. And here's the plan that was put together. And this is back in 1987. Become an autonomous profession, become a doctoring profession, obtain limited license practitioner status, create our own professional organization, develop an Enrich Curriculum, enjoy direct access by all patients, and develop a new professional structure. And these 7 points are interlocking in terms of the key ideas behind them. Of course, one of it, as part of the AUD movement, was becoming a doctoring profession. Well, and then you tie in that limited license practitioner status, or in reading the article, what may be called today limited license physician status, because he writes about operating at the level of optometry. Now, one thing you have to understand about Dr. Osborne is he was first trained as a dentist who then went into TMJ work, which got him involved in audiology. So he went through the professional school environment, becoming a dentist first. And he wanted that to happen for audiology. And his vision was that we would have professional schools that taught a biomedical science-based curriculum, as you would get if you were going into any of the limited licensed physician categories. Now, the LLP categories are not physicians, but they are people who are recognized at that level within their scope of practice. And classic example being optometry. So the goal was get there. Now, what we're trying to do today is to get to limited licensed practitioner status, which is a step between where we are today and limited licensed physician status. But the Enrich Curriculum, the basis of this, the biomedical science foundations, is something that just has not happened for the profession. And we've not done our educational work to lay the foundation for the movement that was envisioned 35 years ago. Some other parts of this are creating an autonomous profession. That's a profession that can take care of itself without relying on anybody else to guide it or to rule it. And frankly, that means completely separating from communication sciences and disorders. I have colleagues, in the CSD environment, and they adhere to the philosophy that CSD makes sense because there is, one discipline with two professions that come out of it. And while that may be the historical basis of our profession, it cannot be the future of our profession, because we can't look to the model being speech language pathology. We must look to the model being the other profession, which treats a primary sense disorder, optometry. How are they trained? How are they work? And that was the vision. And so part of becoming an autonomous organization is you have your own association that represents you. You have your own licensing bodies that govern you in the state. You have your own accreditation agency that governs and monitors your training programs. Your training programs are autonomous training programs. When you think about these limited licensed physician professions, you don't go to the school of dentistry, optometry, and medicine. No, there's a school of optometry. There's a college of dentistry. There's a college of medicine, and these are all autonomous. That was the vision that was laid out 35 years ago. There have been some people who have tried to achieve that through the academic route, but frankly, I will tell you, having been there, it is very frustrating to try to get there.
Well, what's really interesting to me, and part of the reason why I really wanted to have this conversation was because it feels as if, as a young person in this industry now, I'm not an audiologist, but some of this was kind of unbeknownst to me. And I think it's really, when you're looking at the workforce data that we're going to get into, this is providing so much context. So in that 7-step plan, it lays out become a doctoral profession. So in 1999, it goes from being a master's level degree to, in order to become an audiologist, you need to obtain the doctoral level degree. And it's fascinating that all the way back in 1987, this group of gentlemen have identified the need to obtain practitioner status. Now, what's the flagship thing that is trying to be achieved within MASA, for example? The practitioner status, which will give you direct access to patients. So, and in that article that you referenced, the George Osborne interview, he's talking about legislation that was on the floor in 2003 that was going to provide that practitioner level status. So what's, I guess, kind of concerning is that, it's like you've embarked on this path and you're actually at the point of no return because you've already achieved some of the goals that you can't reverse. So you've already made it such that you have to now get the doctoral level. So you've added the burden of that additional year and the costs that are associated with it. But because you haven't achieved the other goals, it's like you're in this limbo period. And I just thought that, as I'm looking at the workforce data, there's so many striking things that come about when you understand that historical context that largely derived from this 7-step plan that is still in progress today, that I think is part of the root of some of the issues that are the audiology community is experiencing, is because they have not fully achieved the goals that were initially laid out to become an autonomous profession.
You're picking up on something that is very important. I can give you 3 examples, firsthand examples, where I've been working on trying to implement the plan, and yet I've hit roadblocks. So let's talk about Enrich Curriculum. Back as dean in 2014, 2015, our residential program curriculum had been in place for a while. And we did an extensive curriculum review to update it, revise it, improve the curriculum for the college. As part of that, I did a survey of the program directors around the country to get an understanding of what they were teaching in their AUD programs and what they thought perhaps would be a model curriculum that we would use that as input into just revising and updating our curriculum. There was a lot of expected results in that, but there was one item that just stunned me, and that was that one of the questions I asked was, of all of these topics that show up in audiology curriculum around the country, are any of them not needed, or are any of them not important enough to include? And there were very few things out of the long list that were not deemed worthy of inclusion by the program directors around the country. That item that was deemed not important was whole body anatomy and physiology. Now, head and neck anatomy and physiology was in all the curriculum, and everybody thought that was important. But whole body anatomy and physiology was not deemed important by the program directors. And again, I was stunned because our program is founded in the biomedical sciences with this vision that we're going to move the profession up to a level where we're operating holistically in patient care. I think about today, some of the biggest avenues for opportunity in the profession is understanding comorbidities associated with audiology. If I go back to the 20th century when I was trained in my master's training, the ear was this little black box that sat in isolation. And now we understand it's not. And it's tied into so many parts of the body, the vascular system especially. And in fact, in some cases, the ear's health and hearing health and vestibular health is an early warning sign of body health problems that are showing up. But short story being, my peer group of program heads around the country saw no need for the biomedical sciences to be part of the curriculum. Yet that was a foundational idea back in 1987. Secondly, around 2013, 2014, about the time that I was able to get Dr. Osborne's 7-point plan republished in ADA's magazine, I was talking about it on the lecture circuit. And I was at a meeting. It was actually the last meeting of the Scott Haug Foundation out in the Hill Country in Texas. And I walked through the plan again and actually called my talk "A Revolution Stalled," because we had made it so far, but only halfway through the objectives. And when I talked about achieving limited license physician or even limited license practitioner status, something like that, I had people in the audience who were presidents of AAA from the early years. And after the talk, they came and just basically told me that was never part of their plan to advance the profession to practitioner or limited license physician practice. And it was still not part of the plan. And so there, it was certainly a problem. The third thing within ADA, prior to MASA, we worked very hard on the Audiology Patient Choice Act. And in that, was a movement up to limited licensed physician status, to try to be on par with optometry. And we could not get a coalition built with ASHA and AAA to all unify around that objective. MASA came about when everybody gave something. And what ADA gave up was, okay, we're going to give up limited licensed physician status, and let's just work on getting to practitioner status. And just getting there would be a significant advance. But there's 3 examples where I know there's a plan in place that was put there 35 years ago, but I've encountered obstacles to implementing the plan over and over again. And I don't think that the profession even understands the plan, has ever seen the plan, or even would agree to the plan today.
Yeah, I mean, I think that this speaks to a lot of the frustration that, just as somebody like myself that is just privy to all the conversations that are had in and around the industry by all the different types of professionals, is the lack of cohesion, the lack of a unified message. I mean, we're talking about a workforce that's less than 20,000, even if you include the hearing instrument specialists. So you're not a big governing body to begin with. There's not a lot of lobbying power there, and way less so if it's fragmented. And so here we are, and it seems as if the audiologists, their purview, their scope kind of continues to be eroded away. And to your point, I don't think I've ever really had, I haven't had a whole lot of consistent answers or just feedback in terms of what's the plan here. And that's part of the problem, is that there doesn't seem to be, I don't know, a unified answer or mentality of what it is that we're seeking to achieve. I think, or I'm saying that as, again, as a third party, but what exactly is this profession trying to achieve? That seems like a big part of the problem, is there's not a consistency in how people would answer that.
Well, I think you hit on something that many people are frustrated about. When I look at the scope of practice, which is at the, it's established at the state level, the scope of practice from when I was licensed initially 40 years ago, God, that sounds old, is hasn't really budged. Yet the degree has changed, built around this idea that there's much more knowledge that needs to be acquired by an audiologist. And the purpose of the degree is to make us a key component of the healthcare system operating at the doctoring profession. With that would eventually come expansion of the scope of practice. We have a saying here at Salus that education precedes legislation. So the first thing you have to do is educate everybody to be able to operate at a higher level. Once you can prove that, then you can go and work on the legislative activity to let's get to the higher level. But as you mentioned, we've been working on direct access for 20 years. This year, we got a crack of the door open just a little bit through the new CMS physician fee schedule of partial direct access. But the other things we're looking for, having Medicare recognizes and CMS recognizes at where we want to be, that mismatch just continues to create problems for us. And frankly, it makes you wonder, why should you put in the amount of work necessary to become an audiologist if you're not actually being able to do more things with your degree than we are today? That's a real problem we have to answer.
I think this would be a good segue to pull up some of the data that you had, that you had done so, because I think that it's here where we can kind of get into. You had said to me earlier, one of George's big premise behind his 7-action plan was that, and I think that this is like really apparent in the data with the rise of the hearing instrument specialist, is audiology needs to move higher and further up into the medical food chain, if you will.
Yeah. When I mean, Dr. Amlani and I started looking at this back in 2019, and we're not the first to look at workforce issues. Doctors Windmill and Freeman had a great publication a decade ago where they pointed out this issue, and there's been others who have zeroed in on it. But I'm going to pull up a graph in just a minute and show you the basic thing that catches your attention is what we have. The best database that we have for our workforce is the BLS database. In 1997, audiology and speech pathology entered the database as a combined code.
Yeah.
2 years later, in 1999, the two professions were split. So we have, from 1999, the BLS data. So that's 22, 23 years of data on what our workforce is. And if you go to that number in 1999 and you go to the number today, the size of the workforce has not significantly moved at a time when comparable professions to ours, speech language pathology, occupational therapy, physical therapy, optometry, have all grown their workforce by 70%. And we haven't. But let's look at some data. Here's the raw data and some of the analysis that Dr. Amlani and I just published in the Audiology Practices fourth quarter magazine. And some of this was based upon, too, a presentation that we made in November at the ASHA meeting in New Orleans. So we have a timeline across the bottom. It starts in 1999. It goes out through the last year of the data, 2021. The y-axis, we have the audiology workforce as reported by BLS. Now, I don't want to say that these numbers are the size of the audiology profession, because there are other estimates of the audiology profession that say 13,000, 14,000, 15,000, 16,000 people. And certainly the professional associations say that. But we don't have their data. It's not publicly available data. This is the only thing we have to work with. But if you look at 1999, we've got 13,000 audiologists. And you come over here to 2021, and we've got 13,200 audiologists. So we've grown 200 audiologists in 20 years. So we're growing at 10 people a year aggregate over the 20 years, as I say. And what I consider our professions, very similar to ours, have grown by 70%. If we'd grown 70%, there'd be 20,000 or more audiologists by now. But also, when you look at this, the blue line, the squares and the blue line, it is wonky data. When I look at data from all the professions, there's nothing out there that I really see that shows this lack of a steady, planned growth in the profession. You have this huge trough that shows up between 1999 and 2008. Hitting with a real low point of below 10,000 audiologists in 2004. That was right smack in the middle of the AUD transition process. And I don't know what was happening. I don't have an explanation, but certainly the data is very alarming. You would hope that in the process of transitioning to a new degree and beefing up your educational structure and having a new vision, that the numbers would be going up, not down. But that shows like a 25% loss in the workforce numbers over a 5-year period, out of which another 5 or 6 years, we've steadily climbed back. And then from 2010 and on, we're starting to see some leveling out of the growth.
Yeah, I like this here because, again, like you mentioned, what happened in 1999? Well, it transitioned from being a master's level degree to a doctoral level degree. Then you suddenly have this, giant reduction in the workforce, down 25%. So I think what's nice about this, I like, aesthetically, this is a great way to map the data because you have three different ways to basically assess it. You have, okay, well, do you want to factor in the period of time, directly after the transition? Because that's going to tell a different story. The Y equals 110, so you're averaging 110 new audiologists entering into the workforce per year. Or do you want to omit that data, 2004 to 2021, where maybe that's a bit of an aberration? And so you're going to look at it that way. Then you're averaging about 152 people, or are you just looking at the most relevant data, say the last 10 years, and that's the green data? But either way, to your point, I think if you look at from, peak to trough or whatever, from 99 to 21, you're almost flat in that span of time of where it was and where it is now from the audiology workforce, which probably segues into the introduction or the emergence of the hearing instrument specialist and the role that, they played in, I think ultimately kind of maybe because of the transition from the master's to the doctoral, it's one of those secondary effects of that. But I know that you compiled a lot of, the workforce analysis that you did is way more comprehensive than just this industry. So maybe there's some other examples from other, ancillary medical industries that we can look to as to similar, the dichotomy of having doctoral level medical professionals working hand in hand with either associate or master level, support type roles or something to that effect.
Yeah, and you did a nice job of summarizing the graph for us. If you're not familiar with looking at regression equations, there's three lines on there. The blue line is the 22-year data. The orange line, you say, well, let's take the low point at 2004 and come forward. And then you can say, well, no, let's look at just the last 10-year data, which is the green line, showing from as you say, from 110 to 150 to 200 people increase in the size of the profession per year. But that's not a growth rate that's going to overcome the loss. I mean, you would expect, that there would be 20,000 or more audiologists. So here's another way to look at the information. So the blue lines represent the workforce numbers for the profession of audiology in the BLS database. In 2012, there were quite a few healthcare professions that were added to the database. One of them was hearing aid specialist. And the red line is that 70% growth line that comparable healthcare professions to ours have followed. And that's where I get you would expect to see that if we were performing on par with the professions like ours, there would be in excess of 20,000, be like 22,000 people. That would be great to see. But you look at the hearing aid specialist data now that's being added to the database, and you can see pretty much where the shortfall in audiology is being met by another profession to meet the needs of the public's hearing healthcare. The failure of audiology to grow our numbers has many, many consequences. But one thing that is very important is if you don't grow your workforce to meet A, the growth in the size of the country, and B, the graying of America, neither of which audiology is doing, someone else has to step in and do your job. And that's exactly what we're seeing in the 10 years that we see the hearing aid specialist data show up in the BLS database. They've more than doubled their workforce at a time where ours has increased by about 15%. And if you project those numbers out in another decade, the two professions will probably be comparable in size. And by the mid 2030s, 10, 15 years out, hearing aid specialist will actually be a larger profession than the audiology profession if nothing changes. And I consider it alarming that we have not grown our workforce. When I think about just trying to think the things we're trying to achieve politically, getting MASA through Congress. If we had a profession that had 22,000 people instead of 13,000 people in terms of talking to our legislatures about demonstrating that we have the capability to fulfill the needs, that would be great. If you go back a year ago when Medicare hearing aids were being discussed, there was discussion about, well, should it be only audiologists who do this for Medicare hearing aids, or should hearing aid specialists be involved? Well, the hearing aid specialists were lobbying on Capitol Hill saying, look at the audiologists who are in the country. They're in urban areas, but they don't have enough workforce to meet the needs of the country throughout the state. And we have people in these other areas where audiologists are. So combined, what we're doing is meeting the needs of the country for at least for hearing aids. I don't want to imply that that's meeting the needs for audiology services, but for fitting and dispensing hearing aids, which is kind of the lowest common denominator for audiology, you see who's providing the manpower that we've created by a lack of growing our workforce.
And wouldn't you say that what you just said right there is, I think it goes back to George's 7-point outline, which is, again, moving up if you're going to become a doctoral profession, then you need to move up the food chain, because you're effectively focusing on the lower complexity tasks that the hearing instrument specialist is able to do as well. And then that sort of calls into, I think it's I have a tendency to look at like, well, are audiologists like dentists? Are they like optometrists? And, when you and I were discussing this previously, you made a really good point about, how maybe the analogy of dental sort of falls apart because of the lack of delineation, I guess, of roles, whereas it's much more well-defined in the dental setting, where a dentist has a very clear role and I guess like a, battery of different services that only they can perform. Whereas the hygienist, if that's going to be the analogous role to the instrument specialist, might actually be the one that's, spending the bulk of the time with the patient. So it continues to kind of bring into focus this need for those 7 steps to be completed. Because if you've only just moved yourself into the doctoral level, but you haven't achieved the other steps, it, in layman's terms, it sort of just begs the question, why go the route of getting this higher level degree that, again, requires more time and money, if you're ultimately going to be doing the same thing that this other role can do?
That's a very good question. Last year, in my presidential address for the Academy of Doctors of Audiology convention, I made this analogy. If you think, and again, modeling on optometry is one of our objectives, I believe. If you think about, you have the optometrist, you have the ophthalmologist, you have the optometrist, and you have the opticians, and they have 3 very clearly delineated roles. And if you think about the optometrist, are they closer to an optician or are they closer to an ophthalmologist? Well, being a limited licensed physician profession, they're closer to an ophthalmologist because they're operating at the doctoral level within their scope of practice. They're not MDs, they're not physicians, they're not specially trained, but they're closer there. Think of that same continuum, the otolaryngologist, the audiologist, and the hearing aid specialist. How are we seen? Are we closer to being to an otolaryngologist or a hearing aid specialist? I maintain that what we are seen as being closer to the hearing aid specialist. And being there is a great deal of value to be done in taking care of the nation's hearing impaired in that role. But that's kind of the bottom of our scope of practice. What we have to do is to prepare ourselves, one, to operate at the top of our scope of practice. And there's a lot in our scope of practice which is potential, but not being explored and not being utilized by audiologists. And then as we ramp up our educational programs on this 7-point plan, then we begin to show that we have the capability to expand and meet more needs. Then you start coming to the audiology environment in which we would love to see. And there's your dentist model coming in. Dentists are highly effective at running private practices, and they have multiple level of extenders who do different functions in, and the dentists don't need to do the basic stuff. I will say it's probably 15 years ago that I made a presentation at AAA. I was on the podium with Dr. Margolis and Dr. Dirks, and we were talking about how are we going to meet the future needs of our country in terms of the role of audiologist. And one of the conclusions from our talk was that we cannot do it by manpower alone. We're going to have to rely on assistants and machines. So machine testing and audiology assistants. And I would add to that now hearing aid specialist. And so for the audiologist to operate at that highest level, at their seeing the complex patients and letting other people who work in their practices take care of the day-to-day issues in patient care, that you do not need an AUD. You do not need an AUD to fit a hearing aid. Let's just be really clear about that. But with an AUD degree, and especially some good training in the biomedical sciences, you can do a lot more. That's where the future of our profession is, I believe. That's how we separate ourselves, create that distance, and move to what is a higher place in, call it the food chain of the medical hierarchy.
Yeah.
You have allied health, you have practitioners, you have the limited licensed physicians, you have physicians. We're at this diagnostic other category. And MASA, the Medicare Audiologist Access and Services Act, which we were unable to pass again in this legislative cycle, has 3 legs to it. How many of the people in the audience know what the 3 legs are? How many of them have contacted their legislator to say, this is where I want audiology to go? I want direct access. I want my patients on Medicare to be able to come see me without having to have a physician referral first. I want Medicare to recognize me as having therapeutic value and not just diagnostic role. And frankly, I want to move up and I want to be recognized as a practitioner where I can begin to show that I have an autonomous profession that can have more value in the healthcare system. That's what MASA is all about. That's the key to advancing the profession. And every audiologist in this next legislative cycle has got to get on board with this and start to become involved if audiology as a profession is going to advance. Getting those 3 things done would be consistent with the big 7-point plan to move the profession forward.
Really well said. And, just again to sort of like hone in a little bit on the distinction. And I think that, ultimately we would be so much stronger, I think, as a workforce and as an industry if there was a harmony between the instrument specialists and the audiologists. And I think that, again, it's like, this problem has sort of persisted and festered of not moving up the food chain to where now we've turned inward in our already small workforce. Now that there's like this division of, trying to maintain, your fiefdom. And I think that you've used the analogy, or maybe the right place to look is optometry. And maybe you could speak a little bit to this, because I do think that I think in many ways they probably are one of the best, you know, guides for audiology, because of the fact that, you know, you look back at optometry in the days before contact lenses, and then, you know, flash forward to Warby Parker. I mean, they've had to really weather some pretty significant storms, and they've come out doing really well. I would bet that most optometrists are doing great today. You know, respective to maybe some of the doom and gloom that was in that industry. Because you look at, like, you know, the role of the optometrist in the past used to be fitting people with their technology. And now it's more about diagnosing complex medical problems. And it goes back again to this whole notion of the, you know, having the aptitude of being this like biomedical field that is much more medical and oriented in those more complex level problems, and letting this, you know, layer of support and extenders, like you mentioned, you know, really spend the time tackling a lot of that. And I know that this all sounds great and stuff like that, but you might be saying, well, the bulk of the revenue today in this industry is around hearing aid sales. I get that. I totally get it. But it doesn't really ever excuse the fact that, you know, that doesn't have to be the way that it all, you know, always has to be. You know, I think that it's part of the challenge of figuring out, you know, it's easy to say, well, you know, the audiologist needs to move further up into the food chain of the medical hierarchy. Well, what does that look like? Like, what are the opportunities that are there? So I kind of want to throw it back onto you, because I know you've thought a lot about this, of what would that look like, and then how does that then kind of relate to this whole analogy around optometry?
David, it's really nice layout of the history of optometry and what they've done, and frankly where I think we have to go. I mean, optometry, we're going through right now a little internal crisis about over-the-counter hearing aids. Optometry went through that when readers went from prescription devices to over-the-counter readers, and they recovered just fine. They went through the crisis again when contact lenses became something that you could get through the internet instead of having to come into the office to get them. And now you mentioned, yes, Warby Parker, you have other people who are entering the device space. And so what optometry has done is they have dissociated themselves in the definition of their career from devices, and have made it about the medical services that they can provide that surround vision care, and vision care as part of whole body health. And yes, the profession is doing very, very well. And they have people who can work for them doing these other things, but that's not what they necessarily concentrate on. If audiology continues to focus on devices, in my opinion, that's a path to failure. And the reason is you've got another profession who's fully licensed to fit and dispense hearing aids, and they do it successfully. We've had 20 years of the AUD movement. I still haven't seen any data that says that an audiologist does a better job than a hearing aid specialist when it comes to outcomes from the patient's perspective. So that profession too, their average wages are $30,000 less than ours. So if I'm in industry or if I'm in retail, why would I hire an audiologist to fit and dispense hearing aids when I can hire a hearing aid specialist to do it? That supports my business model. And following the devices is, I believe, a path for failure for the profession. So where do you go? You follow the path of optometry. You become part of the healthcare system. And we already have a degree. That's what doctors in healthcare do. You are part of the system. Again, you're biomedically science trained. You have to operate peer to peer with the other physician groups in medicine, which begins with where even our undergraduates come from. Well, not our undergraduates, but our undergraduate degrees. We have to become a profession that is attractive enough that we can draw on STEM graduates who want to come in. We can no longer build our profession on the enlightened refugees of communication sciences and disorders programs. We have to have people who are ready to perform at the level where the profession has to go in order to have its autonomy and to be the real profession that has the payoff for the hard work of getting the doctoral degree. But it does mean thinking about yourself. How can I be part of the medical system to truly diagnose and treat hearing and balance disorders and the holistic approach in patient care?
And I well said. And to I think kind of come to a close here, I personally look at the current landscape, and what better of a time with everything that's starting to come out in the science and the research around all of the comorbidities. I mean, there really is, I think, such a gigantic role for this particular kind of audiologist that you're describing to really have a significant role. Whether it's linking all of the things with our, the brain that's such a frontier that the audiologist plays a massive role in. And then down the line with all the comorbidities that are associated with aging and hearing loss and all of that. So it seems like there's plenty of opportunity, but again, it really just boils down to, I think the workforce, having a collective unified vision of what they're ultimately setting out to do, and then having the cohesion as a group to accomplish those goals so that they can ultimately reach that autonomy that we've been talking about today. Because I think that this is not the battle that I think audiology needs and wants to fight, is with the hearing instrument specialist. I just think that's really, it's a complete sideshow. The much more important battle is on figuring out where exactly does, like you said, this sort of middle role, if you will, on the spectrum, and establishing yourself in a way that I think is future proof, much like the optometrist, where you start to disengage from just the being associated with the device. You then are perceived as something much different, I think, in the eyes of the patient and the consumer, as a medical professional that serves a very distinct role that I just think is going to be more and more pertinent as our population gets older and as we learn more about how interlinked all of our physiology is, particularly as you near the brain.
Yeah, David, and the good news is, and there is good news, there are audiologists who are already practicing at this level.
Absolutely.
Now, granted, they don't have practitioner status. They don't have direct access. They still aren't recognized by Medicare as rehabilitative experts. But within those constraints, they are practicing at the top of the scope of practice, and they're doing some wonderful things. And so, what I would say to the younger audiologist is, if you're seeking out if you're in school and you're seeking out an externship, or you're a young audiologist and you're trying to figure out where you want to go, find those audiologists who are working at the top of the scope of the practice and go work with them, go learn from them, go get that experience. And I believe that that's where you will find a great deal of job satisfaction today and a great future for tomorrow. So it is happening. We just need it to be global across the profession.
That's fantastic. Well, Dr. Bray, thank you so much for coming on today, sharing all your thoughts, some of the research and the data. I'm looking forward for the full publication to be published. I think it's going to be something that a lot of people are going to be reading and talking about. So thank you for coming on, and thanks for everybody who tuned in here to the end. We'll chat with you next time.
Thank you so much, Dave. It's been a pleasure.